The neck. The neck. The neck itself can be seen as the bridge between the head and the thorax. And in that neck, we find that there are muscles, and there is also continuity between the brain and the lower parts of the spinal cord. So the transmission is through conduits which link the head and the lower part of the spinal cord. Now, very prominent within the neck are the triangles of the neck. And one can use the sternocleidomastoid as the defining muscle that helps in dividing. It's both defining and it's dividing the anterior triangle from the posterior triangle. The sternocleidomastoid, as you know, has two connections superiorly and two connections inferiorly. The connections superiorly are muscular and fibrous. One can be seen as thick and the other as thin. And the same thing goes for the lower connection. One is thin and the other is thick. The lateral connection inferiorly is thin, and the medial connection superiorly is thin. So there's an inversion between its upper end and its lower end. The sternocleidomastoid superiorly has an attachment to the mastoid process and to the lateral 2/3 of the superior nuchal line. Inferiorly, it's attached to the manubrium, and that manubrium is, that connection is tendinous around the tendon, and then laterally there is a connection to the medial third also of the clavicle. And that muscle, that oblique muscle, divides the neck into a posterior triangle and an anterior triangle. The two of them will give us two triangles on the right and two on the left. The midpoint of the triangle we are talking to goes through the midline. So I have here a right skull, the head of a right cadaver, and I have here the sternocleidomastoid passing down. So this is going to divide the neck into an anterior section, which will be an anterior triangle, and a posterior section, which is the posterior triangle. The triangles will use the midpoint as one of their sides. So for example, for the posterior triangle, we are going to use the sternocleidomastoid. We will use the clavicle and superiorly, and we'll also use the midline. So what happens is that this is a spiral triangle. It's inferiorly, it's broad, but when it comes superiorly, it is going to, as it were, the muscle itself is going to come to a small area. Are you with me? The triangle is twisting as it comes up. So it has, its base is broad, but as it comes to its apex, it is going to become narrow, right? And so we will have superiorly the sternocleidomastoid, and posteriorly we will have another muscle, which is what's the muscle that we have posteriorly? That is helping to form the posterior part of the triangle. The trapezius, right? And inferiorly, the base is going to be the clavicle. Good. Now, between the two muscles, we have skin, we have superficial fascia, we have muscles, we have nerves. we have blood vessels, we have lymphatics. All of those are structures within the posterior triangle. And the same thing obtains within the anterior triangle. There's going to be skin, superficial fascia, deep fascia, nerves, lymph nodes, and muscles. It is just that in the anterior section we are also going to have some glands as well. Salivary glands and the thyroid gland and so on. Okay? The posterior doesn't have those, is not so enriched, but it has important structures anyhow. Now the posterior triangle, its apex is at the, where's the apex? Apex of the posterior triangle is at the level of the superior nuchal line. The apex is at the superior nuchal line, and its base is at the clavicle. Very good. Structures within the triangle. We have to think about this posterior triangle. Think in terms of the floor. What are the muscles in the floor of the posterior triangle? You have done this before. Since you came into medical school, you are doing brachial plexus and all these things. What are the muscles in the floor of the posterior triangle? Because the brachial plexus as well is linked with the posterior triangle. What are the muscles in the floor of the posterior triangle? Omohyoid. Well, when you think of the floor, we really mean floor. We don't mean fellows passing through like omohyoid. Because omohyoid is on his way through, but he isn't really a part of the floor of the posterior triangle. So muscles in the floor are... Okay, let's go a little orderly. Superiorly in the floor, what's the first muscle that we'll find at the apex of the floor of the posterior triangle? Apex of the floor of the posterior triangle is semispinalis capitis. Semispinalis capitis. Just inferior to semispinalis capitis, we have another muscle, which is right here, and that muscle is splenius. 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 Splenius means bandage. And you know how you put on a bandage? You kind of put it on in an oblique way. Well, that is what splenius means. And here is splenius, he's coming obliquely. He has an oblique position in the floor of the posterior triangle. So when, for instance, you think of the mastoid process, the superficial muscle on the mastoid process is the sternocleidomastoid. And deep to sternocleidomastoid is the splenius muscle, and deep to splenius muscle is the longissimus capitis, and deep to longissimus capitis is the posterior belly of the digastric muscle. But we're just talking about the floor. So the floor is semispinalis at the apex, and the next muscle is splenius capitis. Capitis, capitis, capital means head. It's attached to the head. That's the reason why capitis is attached to the name. So semispinalis capitis and then splenius capitis. And then a little below splenius capitis, we'll find a muscle that has a kind of slender look about him, and comes in two groups. And this muscle is the what? Scalenus? No, the levator scapulae. The levator scapulae. Yes, the levator scapulae. So we have first semispinalis capitis, right up at the apex, and then below that we have splenius capitis, and then we have the levator scapulae. Levator scapulae, you remember that, coming from where and going to there. Where is it coming from? Levator scapulae. Levator scapulae. It's a muscle you have dealt with already when you did scapula. What is it that elevates the scapula? The levator scapula. You did that from a long time, and it's like I'm talking Spanish or Greek or Hebrew. Levator scapulae, yes. Where is it attached? Superiorly. The what? Lateral process, C1, C2, posterior tubercles of C3, C4. This 6-week anatomy is giving you a warm time, warm time. Anyhow, levator scapulae is the next one. And then as we go inferiorly, we are going to find the scalene muscles. So we're going to find scalenus medius and scalenus anterior and scalenus posterior. And most inferiorly, we will find a little bit of serratus anterior. First digitation of serratus anterior. So those are the muscles of the posterior triangle. So from above, we have semispinalis capitis, and then we have splenius capitis, and then we have levator scapulae, and then the scalenes, and then inferior to that we have serratus anterior. Alright? And the scalenes, you remember them. We have 3 of them, anterior, median, and posterior. Right? So those are going to be your muscles in the posterior triangle. Structures inside the posterior triangle. We're going to, somebody mentioned omohyoid, so that is passing through. And omohyoid kind of divides up the triangle into an inferior supraclavicular and a superior posterior occipital triangle. But even if you don't remember that, just remember omohyoid passing through. Alright? Where's omohyoid going to? Going down to the omus. What's the omus? Omus. Omus means what? Shoulder. Going down to the shoulder. Yes. Alright. Now, within the triangle, we are going to find some nerves, and significant among them is going to be tell me one significant nerve in the posterior triangle. Pretty high, running from around the junction of the upper third with the lower 2/3 of the sternocleidomastoid. You will have a nerve passing back, which is referred to as what goes through the back, the posterior triangle. If you're walking with a log of wood and you rest it on your shoulder, you might be able to press it and cause some trouble. What is that nerve? Spinal accessory. Right. The spinal accessory is going to leave your jugular foramen, and it is going to run downwards, and it is going to then run backwards to supply both the sternocleidomastoid and the trapezius. And it will also give off, these muscles will also get some proprioceptive information signals from the C2 and C3 and the C4. They will not give sensory information signal. They will not pick up sensory signals from the ear muscle, but they'll pick up proprioceptive. So you know position, where you are. This thing walking on my neck is which part of the neck is running on. You understand? Proprioception, position sense. That will come to C2, C3, and C4. Alright. Now, within the triangle, you will also have some lymph nodes. And one of the common set of lymph nodes that sometimes become enlarged are the superior group. And they Can you tell me one common condition that will cause the nodes in the posterior triangle to be enlarged? One common condition that can cause enlargement of the node. One virus. HIV? That's not common, man. I think these people here behave themselves. Nobody, I don't think any HIV person is among them. So that's not common. Something that is pretty common. As a matter of fact, you might even get vaccinated with it. German rubella. German rubella. Rubella? German rubella. Rubella. German measles. Yes. You don't get MMR. Measles, mumps, and rubella. You never got that. I'm sure many of you have gotten that. Right. So, and that is given routinely. Commonly, if you get rubella, the posterior nodes will become enlarged. All right. Now, okay. So let us just remember again that within your posterior triangle, yeah, man, superior group. Yeah. And then you can also get nodes involvement in terms of more serious diseases like lymphomas and Hodgkin's and so on. So some real diseases you would not want to be associated with in any way. But they can activate any of these nodes within the triangle, both anterior and posterior. All right? But commonly viral stuff like rubella will get your posterior nodes involved. The other structures of interest and importance in the posterior triangle are going to be your cervical plexus and the brachial plexus. Cervical plexus and brachial plexus. Very important. And the thing I mentioned about somebody walking with a log on his shoulder, because the spinal accessory is kind of superficial, it can be pressed on and one can have damage to the paralysis to the muscle if that nerve is damaged. So it's one of the things to bear in mind when you carrying things around, especially things on your shoulder or advising patients. Yeah. Anteriorly, we have the anterior triangle, and the sternocleidomastoid again becomes important, because we can use the sternocleidomastoid as well as the omohyoid to help in dividing the anterior section into a superior jugular triangle and an inferior muscular triangle. All right? So above my stick that I have here, I'm kind of just lining up roughly the position for omohyoid. Omohyoid is coming from the hyoid going down to the... Where is omohyoid going to inferiorly? Huh? Which part of the... Where is it going? Omohyoid is going and sometimes inserts on the transverse ligament that covers the... You don't remember where the artery, the navy, the army and the navy? Yes, right, that ligament right there. He can be inserted on it, right? So this is the kind of rough position he's taking. So above here, we have a carotid triangle, and inferiorly towards the midline, we have a muscular triangle. Yeah, right. It's going to be the muscular triangle. Yeah. And you just look at this carotid triangle, and what is of importance in the carotid triangle? No, we just move from posterior. We're going to finish posterior. We're not on posterior triangle, we are on the anterior part, which is anterior triangle. Then we said the structure of interest in the posterior triangle were going to be the cervical plexus and the brachial plexus. And you also have the nodes as well inside there. Those are structures of importance in the posterior triangle. Yeah. Remember the floor and so on. Right. Anterior triangle, now we have a division here. I use this kind of stick as taking the rough position for omohyoid. Omohyoid comes down and he takes an angle on the jugular, the vein, and then inferiorly he turns backwards and goes to the attached to the suprascapular ligament that is on the superior part of the scapula. I was saying that you remember where the artery goes over, the army goes over, and the navy goes under. In that same location, that's where the inferior part of omohyoid is going to be. So the superior belly then is going to help in forming a boundary for the carotid triangle. Another structure of importance in the anterior triangle is the inferior border of the mandible. Okay, so the inferior border of the mandible is here. So we can use that. And very close, if you look at it, running just underneath the inferior border. What is this thing here? Right. Huh? This is what? What is this coming down here? Tendon of something going towards the hyoid. What goes on to the hyoid? The digastric. The digastric has some connections with the hyoid. There is a posterior belly and there is an anterior belly. Is that not so? And that as well forms another triangle. So if you were to use the hyoid as a marking point, you can think about a couple of triangles above the hyoid and triangles below the hyoid. Are you with me? The hyoid is a marking point. Above the hyoid, we'll have the suprahyoid triangle, suprahyoid triangles, and below it we'll have the infrahyoid area. Okay? Now, using the digastric, posterior belly of digastric here, we have posterior belly coming down, and then this is going to, the anterior belly is going towards where's the anterior belly of digastric going? To the digastric fossa on the inferior part of the mandible. Good. So when it does that, makes that turn with the inferior border of the mandible, you're going to get a triangle. That is called the digastric triangle. So digastric triangle has a posterior belly of digastric, an anterior belly of digastric, and the mandible as forming the three parts of that triangle. Okay? And significant in the digastric triangle is going to be this thing here which has struck, fallen down. What is it? What is this? Submandibular gland. Yeah, the submandibular gland. That is very important. That is going to be within that triangle. Now look again. Towards the midline, we have a muscle. Yeah. We have another muscle right here. And what's this muscle? This muscle going up here. From the hyoid to the mandible. We will have the mylohyoid, right? So we have the mylohyoid, and the mylohyoid itself is going to help in forming another little triangle, which is referred to as the submental triangle. The importance of the submental triangle is that you can have nodes in that area, just below the chin, and some of these nodes are going to drain even areas like the front of the mouth, the lip, even tongue, the anterior part of the tongue, tip of the tongue. Some of the nodes from that can drain into the submental triangle. The importance of these triangles is very significant when you think in terms of drainage of lymphatics from cancerous or from inflamed areas. So if you the presence of lymph node, a lymph node within these triangles, helps in staging the disease. If the disease is very early, it is only within the affected organ. If the disease is late, by the time you pick it up, the horse gone out of the gate. It has left the organ, gone somewhere else. Okay? For example, if the person has a cancer in the tip of the tongue, let us just say a person has a cancer. A person has been smoking or he has syphilis, he in the spirits business. That's what I mean by the alcoholic drinks and smoking and chewing betel nut and all these kind of things. Then they are more prone to develop cancers of the mouth. Right. The cancer can stay inside the area for a while, but as time goes by, it has a tendency to move out of its locale. And what it does is that it moves along the lymphatics to the lymph nodes. So if you have a patient who only has the disease in the primary organ, in this case being the tongue, then you can cut out a piece of the tongue. Okay? Or you can, if it is radio sensitive, you could radiate it. But let us say that the disease has gone later, or he just looked at the thing, he said, you know, there's just a little bruise on my tongue, it's not anything important, it don't pain me, and I don't not going to any doctor about it, I'll just get some bush and drink it, you know. So he stayed there for some long time, and then the disease is going to spread from that area of the tongue into the submental node. So when he comes to you and you feel in the submental area, you could feel this mobile node, then you know his disease is still early, but it has gone beyond stage 1. Are you with me? If the thing now is fixed inside the thing and you can't even move it, although you had cornmeal porridge, you have trouble shaking it because it's attached to tissues around, then you know things are late, you know, he may as well get his box ready. If it's mobile, it means it is still early. But if it gets fixed to tissue around, then it means it has been there for some time, and it is now you're not talking about early disease, you're talking about late disease. Yeah. All right. So remember that we have the jugular, the carotid triangle, the digastric triangle, the submental triangle. A little bit about the carotid triangle is that it is right here, and I wanted you to tell me what is in this carotid triangle. I am kind of just right here. Is the upper part. Remember we said there's a muscular triangle below, using the omohyoid as a dividing point, right? So look in here. Here is my carotid triangle. And I am putting it just like that. I want you to tell me what are the structures there are in the carotid triangle. Boundaries are going to be the anterior belly of omohyoid. Superiorly, you're going to use the digastric posterior belly, and you're also going to use the anterior part of the sternocleidomastoid, superior part of the anterior cleidomastoid. But the structures within here, I wanted you to tell me, it's kind of just obvious sticking out and looking at you. Carotid artery, you can see the carotid artery, and this is the point where the carotid artery divides. So the carotid artery is divided, so therefore you have 3 parts of the carotid there. You have the division, the structures that it forms, and you have what divides. Those are the 3. What is it that coming up to divide? Common carotid. So the distal part of the common carotid is there. And when the common carotid divides, what are you going to give you? Internal carotid and external carotid. So those are the structures within the carotid triangle. Important structures in the carotid triangle. And It is in the vicinity of the jugular vein. So here you have the jugular vein. So it's in the vicinity where you have anterior facial vein coming in. There's also a nerve that is running towards, look at it, sitting right on top here. What do you think it is? Nerve running right on the arm junction. What nerve is going to run on the junction of the carotid? At least two. Give me two. Vagus is going to be there, but also the glossopharyngeal, because remember that it is right in this vicinity here. We have the carotid body. The carotid body. The carotid body, what that deals with? Carotid body deals with chemoreceptors. Right, so if there is a pH change, what's the normal pH of blood? 7.35 to 7.42. So if the pH is going to, if there is more acidosis, then what will happen is that you have, for example, in this place where everybody cough up in this room and there is scarcely any fan running, what do you think is going to happen with all the CO2 that is coming out here? It's going to be picked up, then it is going to be what? Going into carbonic anhydrase activity to produce some H plus and HCO3. HCO3 is going to act on top of the chemoreceptors and is going to stimulate it, send some signals up to the respiratory center, and then you're going to start what? Yeah, hyperventilating. Good. So these are right here to pick up what is happening on the outside and to change the respiratory rate or change the cardiovascular rate as necessary. All right. The one I have it on is a branch of the vagus. Vagus 9 and 10 both come in here. Another time you'll tell me which nucleus it is coming from. Huh? The carotid body is the nucleus, where it is coming from. The what? The parabrachii. Huh? Para means alongside. Brachii means arm. So which arm, where you want to get put this? Yeah, parabrachial is parallel to the arm, alongside the arm. But why you want the arm? Where the signals are going to go to? And does the glossopharyngeal have a parabrachial nucleus? What kind of nucleus does the glossopharyngeal have? That branchiomotor, which is going to feed what? Which muscle? No, this nurse business can't work, you know. Yeah, you have to be specific. Just shoot down right here. Shoot down on this thing right here. Okay? Now, I have the... Okay. Right. Alright. Now, you recognize these muscles? You recognize these muscles? They are the digastric. Digastric is posterior, and the digastric posterior is linking with another muscle which is coming on its anterior side, which is this muscle. The stylohyoid. Can't be mylohyoid. Mylo means molar. Mylo means molar. So the mylohyoid has to do with molar, has to do with teeth. So mylo is going to be on the jawbone. No jawbone is up top here. This is the styloid, vicinity of the styloid process. Right, so back here we have the digastric, And anterior to it, we have another muscle which is coming down and running with the digastric. What is this muscle? This muscle is the stylohyoid. Stylohyoid, yes. And anterior to it, there is another muscle here going into the tongue. This is the styloglossus, right? And between the two is a nice little muscle coming down here with a nerve running on top it. A nice little whitish nerve running on top it. What is that muscle? Stylopharyngeus, right? That is the muscle, and the only muscle that glossopharyngeal, only skeletal muscle, only striated muscle. You know, when you look at it, all the nuclei on the side, yeah, this is the only muscle like that glossopharyngeal feeds. This muscle comes from the third pharyngeal arch, and it is fed by glossopharyngeus. Its nucleus is from nucleus ambiguous. All right? That's the nucleus that feeds the muscle. But when the nerve goes down, it is going to pass between the superior constrictor and the middle constrictor, and then it is going to get into the posterior part of the tongue to give special sensation, special taste sensation to the posterior third of tongue, and general sensation to the posterior third of tongue. That general sensory is picking up, going to which nucleus? The tractor solitarius. What about it will also have some fibers in there that will cause the glands in the mucosal area to get wet when you smell real nice tasting food. The inferior salivatory nucleus. So all of that is coming down in this little nerve. Glossopharyngeal is a nerve with a rich heritage. All right. Okay. All right. Now, what I want to do is just run you through a little bit of the infratemporal fossa, and then we'll come back to face and run up on the scalp. Now, okay, here is an area of importance. Normally we'd have a jawbone inside here. Okay? Right. So when we talk about the infratemporal area, the infratemporal fossa, we are talking about the area in this vicinity. Alright? In other words, you know there's a muscle on top here, muscle attached there, which is the temporalis. The temporalis is going to come down here, pass internal to the arch, internal to the zygomatic arch, and then it is going to insert in what? Into the what? The coronoid process, right? And the anterior part of the coronoid process, both apical and the anterior part. And the fibers, inferior fibers, are going to even come right down inferior or very close to the third molar. Alright? Now, this is the infratemporal fossa, and it's a very important fossa because it has communications with the pterygoid, pterygopalatine fossa. It also communicates with the middle temporal fossa, okay, which is the, cranial fossa, and it also communicates with the orbit through the inferior orbital fissure, okay? So it's a very important area, right? The infratemporal fossa. So the infratemporal fossa communicates with the orbit, it communicates with the pterygopalatine fossa, and it communicates with the middle cranial fossa. Very important area. its roof, or rather its anterior wall, is going to be the maxilla and the pterygopalatine fissure. All right? And then posteriorly, it goes back towards the mastoid and the digastric muscle, posterior belly of digastric. Superiorly, its roof is going to be formed by the temporal bone, the squamous part of the temporal bone, by the tympanum or tympanic plate, as well as by the medial part of the clivus. And don't forget this wedge of bone which is here. What is wedge of bone that comes here? It's only one bone which is a wedge. The sphenoid. So that helps in forming the roof. The sphenoid anteriorly and the temporal bone posteriorly. Okay? And then laterally, you're going to have the zygomatic arch and the medial part of the mandible. At least it's ramus, right? And so it's a very important fossa. Very important for people with sometimes nasopalatine cancers. Yeah. Now, in terms of structures within the pterygopalatine fossa, we will have a nerve coming down here, which is the, which nerve is going to come down here? The mandibular nerve. And there is another nerve that comes down, which is kind of posterior to the mandibular nerve, which is that. The chorda tympani. So think of mandibular and its branches, chorda tympani posterior and its branches. And there are two prominent muscles within the fossa. They are the lateral pterygoid and the medial pterygoid. So it's a place for the pterygoid muscles. Alright? And these pterygoid muscles have a very important plexus, which is almost like the plexus in the leg. Plexus in the leg. But this plexus is a pterygoid plexus. Very important because it communicates with the cavernous plexus on the opposite side. And this pterygoid plexus, because it is so close to the eye, the orbit, it means that infection from the eye, infection from the brain can be, it's a conduit where infection from the eye, infection from the back of the nasal cavity, infection involving the masticatory muscles can be transmitted to the meninges and so on. Alright? Now, there is an important artery that comes into the pterygoid infratemporal fossa, and probably you would say it's the most important artery. What is that artery? Going in the maxillary artery. Very important. And this maxillary artery has quite a number of branches. It has at least 15 branches. So the maxillary artery in the infratemporal fossa has three sections. A first part, which is kind of related to bone, in that all of the branches go into bone. It has a middle section, which is related to muscles of mastication, pterygoids. And it has a third part, which is related to structures linked with the pterygopalatine ganglion. So that is an easy way for you to think about these 15 branches. First, to begin with, pterygopalatine ganglion. Yeah. So the first part of this important maxillary artery that is going to into the pterygomaxillary fissure, passing through the infratemporal fossa. The first part is going to give off branches, which all of those branches go into bone. The first is the middle meningeal. The second is the accessory meningeal. These will go into the foramen ovale and spinal sum. The third is the deep auricular. That is going to pierce the canal of the external auditory meatus. The external auditory meatus has many holes inside it, so the deep auricular will go through to help in feeding the canal of the air. The fourth is the tympanic, which is going to pass through the petrotympanic fissure, which they call the tympanic, right? And the fifth is a large branch which is going into the inferior alveolar foramen. All right? Inferior alveolar, is the artery of the mandible. Right? So it is going to go in the foramen and feed the mandible. Right? So those are the first 5 branches. Run me through quickly on them. The middle meningeal and the accessory meningeal, they are going into the meninges. The deep tympanic, which is going to feed the external auditory meatus, and the the deep auricular, which is going to the external auditory meatus, and the tympanic branch, which is going to go through the petrotympanic fissure, and it will help in supplying bone, right? So those are the first 5. The next 5 go to the muscles of mastication. So there you have a field day. What are they? Branches. Medial pterygoid, lateral pterygoid, masseteric branches, long buccal branch which will go to the buccinator. Okay, and you remember that your pterygoid, some of them, like for example, your lateral pterygoid, it has a head which is coming from the infratemporal crest. It has an inferior head which is coming from the lateral part of the pterygoid plate. Each of them want a branch. You follow? So 5 branches will go to the muscles of mastication. I said 4, but I also said that the lateral pterygoid has a double head. Each of them greedy, they have some serious eating work to go and do. So they need blood. So those are going to be branches to the muscles of mastication. All right. And then we said the next 5 are going to run through into the pterygopalatine fossa, and where those fellows go to, he's going with them. So what are the branches, in other words, of pterygopalatine ganglion? Branch of the pterygopalatine ganglion. What are the branches? The nasopalatine. You have the long nasopalatine. You have the short nasopalatine, or the posterior superior lateral nasal. You have the greater palatine, which is going to run down. You remember that from first term? Run down and go to the greater palatine foramen. You have the lesser palatine, which is going to run down at the back. Remember? With these openings at the back, greater palatine and lesser palatine. And then you also have a pharyngeal branch, which is going to come back through which canal? Palatovaginal canal, and help in supplying the pharynx, the nasal pharynx. Okay? So those are the branches of the next, the third 5. Okay? Alright. We're running again. Let's go to the scalp. Go to the scalp. You will remember that the scalp as we just did temporal fossa, but we just on the outside, the only thing you need to remember is that your temporalis muscle, but we are coming there. The pterygoid arteries, where are they coming from? Pterygoid arteries, where are they coming from? The middle, come on, the middle one. Remember we said the maxillary artery has three parts. It has a first part. All of the branches from the first part go into bone. It has a second part, and that second part is what? Muscles of mastication, and your muscles of mastication are the medial pterygoid, lateral pterygoid, masseter, and the temporalis. The buccal buccinator is more like a face muscle. Yeah. No. Sorry. It's probably a little confusing, but when we talk about the muscles of mastication, we mean that those muscles that are going to, what you do when you masticate? You mash the food. Yes, you mash the food. Grind it down. That is what mastication is. Good. So you need some powerful muscles. You have people who hold up their weight 200 pounds biting on something. Yes, 200 pound weight. You can imagine that? You just have to make sure your finger not in that man's between his teeth. 200 pounds. Hold on like that and hold his weight suspended. People, that has been done. Sorry. Good. So when we talk about the muscles of mastication, we're talking about those muscles with some real firepower. You get me? The masseter, you have a tough bone to bite. What will buccinator do? Buccinator can't do anything like, all he can do is just keep things in the mouth. You understand? So he's not really a muscle of mastication. You can call it's like an accessory muscle. But that don't mean he can't get a blood supply. So the long buccal from the middle part to the maxillary will feed him. Okay? After all, he's contributing to make sure things come on top of the teeth. You follow? When a person has a seventh nerve lesion, his mouth twists, water begin to run out on the side of his mouth, he can't blow a trumpet because buccinator paralyzed. Are you with me? Boy, you're looking to me so like you're so blank, as if I'm not having a feedback on the inside. Are you with me? So when we talk about mashing the food, we want to pull up the mandible. What are we going to pull it up with? The masseter, we're going to bring it up to the head. Masseter, through this thing. We're going to use the temporalis. We're going to bring the lateral pterygoid into play. And the medial pterygoid to help with moving the mandible. Are you with me? So we can get the sharp, the truth aspect. You all should have done these things before, then you could talk like it, like you're making jokes. Alright, but so when you talk about the muscle mastication, think about those strong fellows with a lot of generators inside them that will help in bringing the food together between the molars to be crushed. Alright? And buccinator doesn't have any. He's just like a little accessory fellow. He's not really helping to mash any food. You understand? Buccinator is on the side. He's just kind of keeping things in the mouth. You follow? Very important, but he's not a masticatory muscle. Right. Okay. We can run? Can we run? Any question? Good. Okay. I was saying that the scalp has basically 5 structures, skin, connective tissue, aponeurosis, loose connective tissue, and periosteum. Good. But, listen to this. When you come to the side of the skull, that's not true. when you come to the side of the skull, what we said there does not apply. That 5 baby stuff that you heard about, that is only for the superior part, the valve section, not for the side, because we have other structures in the side. Okay? So look. So let's use the scalp thing as a way of helping you to remember. So we have skin, S. We have C for connective tissue. We have that. And then when we come to A, it can't be occipitofrontalis, because the only thing we could get of occipitofrontalis from here is a little bit of fascia. All right? But we also have some muscles related to the air, the auricular muscles. So those muscles are going to be within that group of the occipitofrontalis fascia group. You're going to place the auricularis. So your superior auricularis, your anterior, your posterior auricularis, they are going to be within that third group. Okay? And then the L now, we'll still have some fascia, but that fascia is going to be fascia from the superior ridge of the bone. That is going to present a fascia layer that is coming down to the superficial fascia from the parietal bone. Alright? You have a parietal crest, so parietal lines, and so from those you're going to have a fascia layer. And then you're going to have your serious temporal fascia, which is very thick. Temporal fascia is going to be there, and then deep to that you're going to have the temporalis muscle, and then deep to that you're going to get onto your periosteum. So remember that when you come to the sides of the skull, the little fighting business does not apply. That only goes for up top. Right. Superficial fascia, and then you have your deep temporal fascia, which is very rigid. Underneath that rigid fascia, you have your temporalis muscle, right? And then underneath that, you have your periosteum. So you have a couple more layers to engage with on the side of the skull. Now, in terms of the blood supply, the scalp is richly supplied with blood. You only have to get a man getting mad and chopping another one, and you realize the significant amount of blood loss that cannot come from the scalp. Now, there are 3 major arteries to the scalp, which are anterior to the ear, and 2 which are posterior to the ear. So use the ear as a kind of dividing point. More of the skull is anterior. So let's give the 3 up top here, no? And less is back. So we give 2 at the back and 3 at the front. And what are those? We use the air as a landmark. So we say anterior to the ear, we're going to get 3 arteries. And posterior to the ear, we're going to get 2 arteries. Okay, give me the ones at the front. Supratrochlear, very good. Next one. Come on, man. Supraorbital, very good. Is that medial or lateral to supratrochlear? The supraorbital is medial or lateral to supraorbital? Which is medial? No! Supratrochlear is medial. Yes, supraorbital is lateral. Yeah. Supraorbital is lateral. Supratrochlear is medial. Okay. Alright, so supraorbital is lateral and supratrochlear is medial. Good. And then the next artery we are going to have is the superficial temporal. Superficial temporal. And you can feel the superficial temporal. Oftentimes, if you press on your temporal area, you can feel the pulsation, right? And then posterior now, we have two. We use the air, posterior auricular, and the occipital, right? So those are going to be your branches. The supraorbital and supratrochlear are going to be branches of the ophthalmic division. I said something here and I kind of, what did I say? Oh, the branches, supraorbital and supratrochlear are coming from the ophthalmic division. And you know the ophthalmic is coming out from the internal carotid. And you know the ophthalmic is the first branch that comes out from the internal carotid when it comes through the cavernous sinus. Shoots underneath and